Hello, my name is Cordell Lucas. I am a acute care nurse practitioner student. I am presenting a case to you today. This is my ID. I am a registered nurse in this ID, Cordell Lucas, same as my face. Today I'm going to be presenting to you a case with endocarditis. A little bit of the background of this patient is that is an IV drug user. The patient has multiple comorbidities, which you would learn a little later in the case. The objective of this grand rounds or presentation is for you to understand how do we manage and treat patients with endocarditis, the risk factors as well that put this patient at risk for developing endocarditis, as well as how do we effectively manage, treat, and hopefully prevent it from reoccurring. Today, the patient's information, initials is AG, age is 69-year-old male, race is white or Caucasian. Chief complaint is chest pain and fever for at times 1 day. So AG is a 69-year-old male who is presenting with chest pain and fever times 1 day, past medical history of hypertension, type 2 diabetes, hyperlipidemia, IV drug use actively. Patient has no known allergies. Patient was hospitalized as a child for appendix removal. Patient currently takes metformin, 500 milligrams to manage diabetes, PO, twice a day. Lipitor, 10 milligrams once a day. Metoprolol, 25 milligrams twice a day. And he also took for the fever and the chest pain Tylenol 650 for fever. Last time was about 6 hours ago. The patient is an IV drug user. Heroin is his drug of choice. The patient does participate in a needle exchange program in New Haven, Connecticut. So currently the location of the chest pain is in mid-sternal chest pain. The onset has been for 1 day. He complained or presented with heaviness in the chest. In his words, he felt like if an elephant was sitting on his chest. The associated signs and symptoms with this was fever and chills. And he says that what exacerbates it is when he tried to lay flat, and what makes it feel better is when he sits up and he stays sitting. The severity of the pain is actually 8 out of 10 on a scale of 1 to 10, 10 being the worst. Current medication is as reviewed at the top. In the last thing, I reviewed one more time, which would be metformin 500 milligrams twice a day. PO, we have Lipitor 10 milligrams. PO once a day. We have metoprolol 25 milligrams. PO twice a day. Patient does take Tylenol or took Tylenol 650 for fever and pain, and this is PO. Patient has no known allergies and past medical history as noted above. In the summary, I'll repeat again for you, is hypertension, type 2 diabetes, hyperlipidemia, IV drug user. Patient's vaccines are up to date. Tetanus was last given 6 months ago when he was injured at work. For his social history, patient currently lives with a friend in a 2-bedroom apartment. Alcohol use is during like social events. It has been normally 1 to 2 beers a week. No tobacco use. Patient is currently working as a laborer in a hardware store 3 days a week. Patient uses heroin. Last time used was 2 days ago, and that was just before he started to feel sick. Family history: his father had type 2 diabetes and hypertension. He passed away at age 89 from a MI. The mother had hypertension and hyperlipidemia, who passed away at 100 years of natural causes. Patient has no siblings or children. Surgical history: patient appendix was removed as a child. No exact date indicated. For mental history, patient has no past expression or current expression for anxiety, depression, homicide, or suicidal ideation. Violence: currently no concerns for safety with persons, home, community, or sexual currently. Reproductive health: patient is currently sexually active and uses protection. Patient has sex with women. In the review of systems, this patient is well appearing, no distress, ANO times 3, everyday moods, but is complaining of chills and, of course, fever from the flush area of the face. The HEENT currently has corrective lenses, no eye discharge, no redness, no dryness, no itchiness. Currently no complaint of postnasal drip or nasal bleeding, congestion, or cough, or sore throat. For the skin, no rashes or lesions present. Did have some track marks from needle uses. Cardiovascular: chest pain, 8 out of 10. Chest pressure and some chest discomfort. No palpitation or edema noted at this time. Respiratory: no cough or shortness of breath or sputum. GI: no nausea, vomiting, diarrhea. No abdominal pain or blood in the stool. GU: no difficulty urinating, no foul urine output, no burning on urination noted at this time. Neurological: no headache, dizziness, syncope, paralysis, numbness, or tingling in the extremities, and no change in bowel habits or bowel control or bladder. Musculoskeletal: this patient has no complaint of muscle, back pain, joint pain, shuffling, loss of balance or strength, or difficulty walking. Hematological: no anemia, no abnormal bleeding or bruising. For psychiatric, the patient has no complaint of depression, anxiety, homicidal or suicidal ideation at this time. For endocrine or endocrinology, no reports of sweating, coldness, heat intolerance, polydipsia or polyuria at this time. For allergies, no known allergies. Patient has no history of asthma, hives, or rhinitis. Lymphatic: no enlargement of the nodes and no abnormal spleen or history of splenectomy. Currently, for physical assessment, we have vital signs. Temperature is 38 Celsius, which is 100.4 Fahrenheit, and this was done oral. Palpable pulse is 99. Blood pressure on the left arm, it's 128/8. Respiratory rate is 16. Effort is unlabored. Weight is 70.5 kg, which is 155 pounds. currently on examination for ENNT. We're looking at Perla with the eye, so pupils are equal, wrong, and reactive to light. Normal hearing test on examination of the scalp. There's no rashes, lesions. Thyroid is normal size. For our cardiovascular, chest pain, it's currently 8 out of 10. PMI is at normal location and pulsating. Normal pulses, +2. We have no pitted edema, no murmurs, no gallop, and no rubs. For chest and respiratory, we have chest is normal movement, symmetrical, no trauma present. Breath songs are clear without any wheezing, rhonchi, rales bilaterally. Abdominal, normal bowel songs or normal active bowel songs that are present throughout, soft and non-tender, no evidence of hepatic megaly. For neurological, patient is ANO times 3, cranial nerve 2 to 12 is intact, no nystagmus. Strength is positive 5 out of 5 with movement. Gait is normal or steady. Musculoskeletal, normal muscle tone, strength, and good range of motion. GU and rectal, no CV tenderness. Testicles are average size for age. No evidence of hemorrhoids. No lesions around the penile area. Prostate is normal size. No evidence of BPH. Immunity, we're looking at no evidence of allergic reactions or autoimmune processes. For the skin, it's warm to the touch. No lesions, sign of trauma, track marks are present from needle use. Lymphatic, no swollen glands, extremities without edema. Hematologic, no evidence of abnormal bruising or bleeding noted at this time. For this patient, we have run some diagnostic testing, which included a CBC, a BMP, a ESR, a CRP, an echocardiogram, blood cultures, chest x-ray, and an EKG. Our differential diagnosis for this patient presented with bronchitis, pneumonia, myocarditis, and pericarditis. The reason we came up with these diagnoses is that the signs and symptoms of cough, chest pain, chills, and fever is associated with all of them. We noted in the note the treatments and recommendations for them as well. In our plan, the patient is actually diagnosed based on the results from the blood culture, which came back with strep, which was positive for strep, which showed up vancomycin was recommended based on the sensitivity. It was 1 gram of vancomycin Q12 hours for 4 weeks. The x-ray showed an enlarged heart with mild pulmonary edema with a small pleural effusion in the left lower lung area or pleural space. no interventions recommended by radiology. CRP was 20 and the SED rate was 50. The CBC read 6.4 for the PRBCs, 26,000 for WBC. Platelets was 215. HNH was 40 and 13.8. Our reflection on this case was based on the examination and the results that were determined. Also, we didn't have the echo results, but the enlarged heart and a positive blood culture gave us the indication that this patient definitely had a source of infection. And based on the blood culture results and the history of this patient being IV drug user actively, put them at great risk for having endocarditis. And with that chest pain, we were able to identify it. However, this patient did not have the genuine lesions that normally appears in the palm in severe cases. However, based on further results from the echo could give us the function of the heart itself. And we also have a lot of recommendations. So this patient will be referred to cardiology for follow-up or management while in the hospital, as well as infectious disease. Because of the high risk, this patient is admitted to a telemetry unit because of the endocarditis, which would have telemetry monitoring capability. Now, this person also would be referred to rehab if indicated, or detox. This person or the patient would either have to remain in the hospital to finish the course because it may require a PICC line, and because of the history of IV drug use, it might be great risk to have this patient discharged to the community. However, the plan after discharge for this patient will literally require us to also prescribe Narcan and prophylactic because of the high risk for HIV as well, prophylactic HIV medication, which is similar to PrEP. We also are concerned about teaching caregivers, family members, or providing kits for Narcan as well, just because of risk for overdose with heroin. This patient also would be recommended to VNS or visiting nurse services, who may need to do follow-ups and checking with this patient. Currently, the patient does not have a primary care, so we would refer them to one of our practices that also offer methadone Suboxone programs and are able to support this patient if he decides to go into detox. I want to thank you today for taking the time out to listen to my presentation, and I look forward to also learning from yours. Thank you. Bye-bye.